Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for Extract 1. Extract 1. Questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Morning, Sarah. I'm Dr. Neil Strathmore. I'm a cardiologist, and you've been referred here from the Royal Children's Hospital for some further follow-up. So why don't you tell me a bit about yourself and what's been happening to you?
Well, I was born with a congenital heart, and I've had surgery in 1991 to correct that. And I was also, a pacemaker was also put in, and I've been seeing my cardiologist at the Royal Children's Hospital since then, and now I've come here.
So in 1991, how old were you?
I was 6.
And how old are you now?
I'm 23.
And so you obviously don't remember much about that, but what did your parents say was the problem with you when you had the surgery?
Well, they tried to explain what it was, which was transposition of the great vessels, but basically they told me that I was out of breath, and that's why I couldn't keep up with the other kids, so I was going to have an operation to make me better.
Do you have any memory at all of the surgery or of being in the hospital?
Yes. I remember the nurses, and I remember the playroom, and I remember finding it really difficult to walk after the surgery.
And so do you remember the fact that you weren't able to keep up with other children when you were little?
Not so much, but I remember my lips turning blue and my fingernails being blue and basically going blue when I ran out of breath or running too much.
So after you'd had the surgery, did you only ever have one lot of surgery, or did you have to have repeated operations?
It was just the one in 91.
Good. And so after that, how did you get on in terms of your exercise capacity?
I didn't start off doing too much, but then afterwards I had been doing ballet beforehand, so I continued on with that. And then I picked up some more dancing, and as I got fitter and older, I was doing that quite consistently.
So during your teenage years, how fit were you?
Fairly fit. I was doing about 5 hours of dance a week, so...
Gosh, that's quite a lot, really. That would be quite tiring.
It was.
And so have you kept that going since you've left school?
I have, but definitely not as much because I've been busy with uni and things like that.
So how fit are you now?
Probably not as fit as I'd like to be, but I'm still taking classes and walking regularly.
So do you have any symptoms? Do you have any shortness of breath?
No, not really. I try to keep watching other people when I'm in classes and making sure that I'm not more out of breath than they are. But normally when I'm turning around, everyone seems to be as puffed.
So if you walk up a hill or walk up a flight of stairs, do you get short of breath?
A little bit, but not enough to be concerning.
So you think you're about the same fitness of other girls of your age?
I think so.
Okay. Now, what about your health otherwise? Do you have any other health problems?
No.
You've already said your breathing's okay. Do you have any cough or sputum?
No,
Any wheezing or asthma?
not at all.
Your waterworks, do you have any problems with your urine or bladder?
No.
What about your bowels? They're all okay?
Yep.
And your appetite, and you don't get any nausea or vomiting or anything like that?
No.
And do you get any headaches?
Headaches I get every now and then, but I think that's mainly to do with stress.
Okay. Do you smoke?
No.
Alcohol?
Yes.
How much?
Every now and then.
So on an average week, how much would you drink?
It depends. Probably just once a week.
Mm-hmm. And would that be 3 or 4 drinks or more than that?
Probably no more than that.
Okay. What about recreational drugs?
No.
Not at all? Good. All right. Now, do you ever have any pain in the chest?
No, not at all.
Do you notice palpitations where your heart's beating fast?
No.
And have you ever had any blackouts or dizzy spells?
No, not at all.
Do your ankles ever swell up?
No, not that I've noticed.
Mm-hmm. Have you had any problems with excessive bleeding or bruising?
I notice I bruise quite easily if I just bump into things, but not enough to be too much of an issue.
Okay. Is there any family history of any heart problems?
No, not at all.
None of your parents or siblings had any congenital heart
No.
problems?
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello there, my name's John, and I'm going to be the doctor that's looking after you today.
Hello, John. Nice to meet you. And thanks for seeing me today.
How should I address you?
Just please call me Kevin. Yeah, I'm here today because I had a bicycle accident on Sunday morning, and I was wondering if you could check me out. I've hurt my shoulder and my wrist, and I'm just a bit concerned about it.
Okay, Kevin, this is the first time that we've met, I believe.
Yes.
Can you tell me a little bit about yourself?
Well, I'm 53 years old. I'm in pretty good health. I'm about 83, 85 kilograms. Probably could lose a bit of weight. My cholesterol's at lower than average levels by far.
And what about your blood pressure? Is somebody checking that regularly?
Yes, again, fine. If not on the low side, yeah. If anything, I tend to be on the low side of blood pressure and that type of thing.
And you're not on any medications at the moment?
No, nothing.
Are you allergic to anything?
No. Never been allergic to anything. I bicycle regularly about 100 to 150 kilometers a week.
Have you ever smoked?
No.
What about alcohol?
Not too much. I tend not to drink that much at all.
When you do drink, what do you prefer to drink?
Recently, I've been just having New Zealand Whites, actually.
Yes. And how many glasses a night would you have?
In a week, 3 to 4. I mean, but that's like 2 on a Friday night and Sunday afternoon, that kind of drinking. It's pretty light, really.
Okay.
I'm conscious of drinking and smoking.
Any history in your family in terms of your mother and father with diabetes or heart attacks?
No, nothing like that. No, yeah, my mother was a heavy smoker. She was a very strong woman, but she smoked a lot. My father also had a bit of heart problems. He ended up having a pacemaker for 30 years of his life. I'm 53 years old. He got a pacemaker at 54, so I'm very conscious of again, staying in shape because of my father's experience. He had that for 30 years.
But it was never that he had a heart attack?
No, it was just simply the heart started. He lived till 84, 85 years old, so perhaps I should tell you one part of my life story. I was in West Africa for several years. Probably the biggest health crisis in my life is living in West Africa for a long time. Have a lot of stomach problems, problems with giardia, malaria, and actually amoebic dysentery. those infections brought my weight down to about 60 kilograms. So just terrible, if you will, diarrhea constantly.
Yeah, and I imagine that you would have required medical treatment for your various conditions as well. Did you spend any time in hospital?
So we used to go to the local embassy and get treated by embassy medical staff. At the time, we were getting 500 milligrams of the anti-malaria medicine chloroquine, and then we had various antivirals and shots, but pretty minimal medical care, to be honest. Yeah, but since then, I've been fine, actually. I've been here in Australia about 20 years and was originally born and raised in the States.
I see. Can you tell me more about the accident?
Yes. Just recently, I went over the top of a friend I was bicycling with, went over the top of him and ended up just smashing myself on the asphalt. And it hurt my shoulder. Yeah, it's terrible. To be honest, he wasn't paying attention. We had just stopped and they were just getting going again. It was Sunday morning. He slammed on his brakes and then I went over the top of him and then into the traffic. And luckily, I pushed both of us out of the way before a car came roaring past. And
wow, that sounds like quite a large accident. Everybody managed to walk away from it okay?
Yeah, we were laughing about it, you know.
You didn't need to call the ambulance or go to hospital for anything at the time?
No, we didn't even think about it. It was, again, we were laughing about it and went to the coffee shop. It was only, you know, as I came home and after the coming home and resting for a while, I realized I was in more pain than normal, if you will.
How long before the pain started to come on?
Right after having coffee, to be honest. I think the adrenaline went down and just coming home and finally kind of reflecting on the whole thing. After the accident, as you know, bicycles have...
That is the end of part
5 to 30. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. Now look at question 25. You hear a nurse reporting to a medical team about a patient. Now read the question.
We have one geriatric patient, Mr. Drake, in room 242. He's had 2 strokes in the past, and there's some cognitive impairment. The reason he was admitted from his nursing home yesterday was essentially that he's been refusing food for 3 days. But there are definitely signs of depression. Last night, the duty nurse reported that he was saying, "I want to die, I want to die," though he didn't say this to me personally. Apparently, his wife's in another nursing home. They have no contact and she's not been able to visit him. So we're going to try to figure out how to get them together because that'll give him something to look forward to. In the meantime, the plan is to get him up. We'll start with the cardiac chair until physiotherapy can see him.
Question 26. You hear a hospital nurse talking to a patient about oxygen therapy. Now read the question.
Mr. Anand, here's the oxygen mask, which we agreed would be a good idea while you're having breathing problems.
Oh, thanks.
Now, it's really easy to operate. Have you used one before?
Yeah, at home last year for a fortnight. I think I remember what to do.
Good. So you're aware of the effect on your mouth?
I'll keep drinking a little and often, because otherwise the oxygen can dry it out, can't it?
That's right. You've got to keep hydrated, so do shout out if your water jug needs refilling. Do you have any other concerns?
Well, last time the skin here behind my ears got quite painful and raw because of the elastic straps tight against it.
Well, if you use these little pads and loosen the straps, it'll stop that happening.
Great.
Question 27. You hear a surgeon briefing her team about a patient they will operate on later in the day. Now read the question.
And the next on today's list is Freddie, who's a cloacal exstrophy with a cross-fused ectopic kidney. He has a history of respiratory infections too, and there's a high risk of him getting another one following the procedure, so he'll need to be in the intensive care unit. We obviously can't start until we hear there's a place for him there, but they're calling us shortly and they sounded pretty positive this morning. This is today's main case, and I'd like to get started around midday so we can spend the whole afternoon focused on this.
Question 28. You hear two hospital nurses talking about a patient's medication. Now read the question.
Now, Mrs. Thompson here needs IV administration of her antibiotics.
Okay, I was a bit worried about her swallowing reflex actually. She's hardly touched her food since she came in. But she's been assessed by the therapist who said there wasn't a problem.
She's been unable to keep anything down since yesterday morning anyhow, so there's no point trying to give her the tablets.
I see her operation's set for Friday morning, so she won't be able to eat in any case in another 72 hours. But that still gives us a window for the antibiotics. We'd still better use IV to be on the safe side.
No problem. I'll set up the drips straight away.
Question 29. You hear a pharmacist talking to a customer about head lice in children. Now read the question. Hello, can I help you?
Yes. There's nits going around my son's school. I need something that'll stop him getting them, because they spread like wildfire, don't they?
Has he got any symptoms? Has he been itchy or had a rash?
I'm not saying he's got nits, it's more that I want to make sure he doesn't get them.
I understand that, but unless your son's been confirmed as having head lice, it isn't advisable to use medication.
I was told there was a lotion you could buy over the counter. I mean, if the nits jump from one kid's hair to another, it's only a matter of time. What's the point in waiting?
Well, first of all, they don't jump. To get head lice, your son needs to be in very close contact with another child who has them. Even then, it's by no means a foregone conclusion. Also, if they're detected early enough, you might get rid of them by combing alone. If that didn't work, well, then we'd recommend a lotion. Question 30. You hear an ophthalmic consultant giving feedback to a trainee who has just carried out an eye examination. Now read the question.
So, were you happy with the examination?
I think it was okay overall, but it was hard carrying out the procedures while having to deal with the patient's questions at the same time.
Yes, that can be hard. But there were lots of good things. Reassuring the patient when necessary certainly helped the process. The patient seemed rather confused sometimes about what you wanted him to do, though. That's something to work on. Think about effective ways of communicating what's required. You described in full the reasons for the various procedures, and adapting your language style to this particular patient did seem to relax him. That sort of approach puts patients at ease.
Right. Thanks.
That is the end of Part B. Now turn over and look at Part C. Now look at Extract 1, questions 31 to 36. You hear an ear, nose and throat specialist called Cynthia Davison giving a presentation about the causes and treatment of nosebleeds. You now have 90 seconds to read questions 31 to 36.
Good afternoon, I'm Cynthia Davison, and my presentation will focus on the causes and treatments of nosebleeds and the implications for those of us working in the health service. About 60% of people get nosebleeds at some time in their life, particularly children and old people. Most of these events resolve spontaneously, and the mortality rate from nosebleeds is extremely low. But treating them still costs the health service a lot of money. In my own hospital, over 40% of admissions in ENT involve nosebleeds. Ideally, we treat many of these as outpatients, yet the majority of those patients will stay in for 5 days. Last year, in my department, €250,000 was spent on the management of this condition. Clearly, any saving on that, if duplicated in hospitals across the country, would have a positive impact on resources for other services. The biggest enemy of the nosebleed is artificial air. In hospitals, we get an awful lot of older people coming in with nosebleeds in winter months. As you'll know, such patients don't tolerate the cold for various reasons, so they tend to sit beside radiators and heaters, and these dry up the air. This means the cilia, which protect the lining of the nose, dry out, and this in turn exposes the blood vessels, which causes bleeding. Our noses haven't developed a defense mechanism against artificial air. 300 years ago, everybody lived in drafty houses and cold environments. Now we all sit in heated rooms, and the nose hasn't adapted to this. The evolution of an organ can take millions of years, in fact. The immediate cause of a nosebleed can be local trauma or inflammation caused by a simple cold, but systemic diseases have to be ruled out in all adults presenting with the condition. People with chronic allergies in the nose are more prone to nosebleeds, and there are some other serious conditions that can present in this way, including cases where the kidney or the liver is no longer functioning as it should. Foreign bodies that enter the nose by some means can trigger nosebleeds, though these are more common in children than adults, and usually there'd be a foul discharge associated with the foreign body. But for a lot of the nosebleeds we see, about 30%, we can't find a specific cause. A lot of people who are at the age where they get high blood pressure are prone to nosebleeds, but the blood pressure itself doesn't cause them. So when we see an adult with a nosebleed, we have to consider the systemic cause, not just look at the event itself. Now there's a pathway of care associated with nosebleeds. First of all, it's advisable to check whether or not a patient's in shock. A loss of at least 500 ml of blood is needed to get the early signs of shock, and it's rare to lose that amount during a common nosebleed. But if you ask any of my colleagues in ENT what they most hate dealing with, it's nosebleeds. This is because they tend to come in late at night. The patient's often scared, and that sets their blood pressure off, making any further diagnosis and treatment problematic. So before you can do anything, you have to allay their fears. You might even give them a sedative to try to relax them. You also need to check they're not on any medication, like aspirin or warfarin, that might affect blood clotting. The next step is to try to find the precise source of the bleeding. The simplest way to stop it is to apply a silver nitrate stick to that point. It's fairly atraumatic, but you can't get those chemical sticks to the back part of the nose, so they're mainly useful for children who tend to have fewer bleeds from that area than older people. Unfortunately, what often happens when an older patient goes into an emergency department and there may be no ENT service available, as many such departments don't have them, what often happens is that because there's so much blood pouring out, the bleeding point can't be located. In this case, a gauze pack will be put into the nose, both in front and behind the nose, to try to put pressure on the whole area and stop the bleeding that way. This can be very traumatic for the patient, and there's also a danger of secondary infection if it's left in too long. So the ideal management is to identify the bleeding point and stop the bleeding directly by cauterizing it or by ligation of the vessel. And this primary treatment will work 94% of cases. So before I go on to...
Now turn over and look at Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42. You hear a specialist in medical ethics called Anna Capston giving a presentation on the issue of burnout in the medical profession.
Hi, I'm Anna Capston from the Division of Medical Ethics at University College. Today I want to discuss the quite urgent topic of burnout among medical professionals as it's becoming. It's kind of an epidemic, but I really think that we're not talking about this enough. That's why we're here today, to get a bit of information out there and start a conversation. So, what is it? Well, burnout is a psychological and behavioral syndrome. Emotional exhaustion is one quite common hallmark of burnout. It's been defined as long-term, unresolvable job stress, a sense of being overwhelmed and depersonalized and lacking a sense of personal accomplishment. A recent study from the Mayo Clinic showed that in 2011, 45.5% of doctors reported that they felt burned out, and that number has now risen to 54.4% in 2014. More than half of all doctors in this country are saying, "I really feel that some aspect of my work as a doctor is making me feel burned out." This is really trouble. It's trouble because a doctor who feels this way can commit more errors. They suffer from compassion fatigue or just not being able to empathize with others because they have their own emotional issues. They may retire early, therefore reducing the workforce. They may have problems managing their own lives. 400 doctors committed suicide last year, which is double the rate of the population average. There's trouble for patients in having a workforce that's burned out. There's trouble for doctors in terms of their own health and well-being. We don't talk about it much. We like to think that doctors can handle everything, but it's clearly not true. It's a problem, and there ought to be some solutions. One type of fix is to make sure that hospitals and other healthcare environments try to create better conditions for a happy workforce and for happier doctors. This might include yoga, mindfulness training, having more therapists to talk to, encouraging people to come forward when they feel this way, peer groups, and better mentoring. There are a lot of tactics that we could pursue and try to engage in. I'm not sure what's best, and maybe one size does not fit all, but it's time to really build a safety net so that we can keep our workforce functioning and we keep physicians at their careers and doing a good job, not making mistakes, not being indifferent to patients, and not harming themselves. This really is a problem, and we've got to attend to it in the workplace. It's just as important as any other aspect of workforce safety. When we institute new software or when we have new bureaucratic regulations, I think somebody ought to ask, what does this do to the workforce? If one more doctor complains to me about Epic and other types of electronic record keeping and billing forms, it'll be one doctor too many. It takes a lot of energy, makes a lot of people unhappy. A lot of the software and computer assistance that's out there doesn't seem to help the doctor. It makes more work or makes them feel frustrated. It also seems to me that if you look at what's going on with respect to regulations and administrative or bureaucratic requirements, nobody is saying, hey, is this user-friendly? What's the burden that it's putting on the doctor? It's just done to save money or allow people to collect bills more reliably, but it's not asking what it's taking out of our workforce. I believe that morally, we've got to make sure that a highly trained workforce that takes a very long time to get the ability to practice medicine is a resource that we preserve and really take seriously. I don't think we're doing that as part of employee or workplace safety. I think it's crucial, but it's being ignored. We also have to view it as part of patient safety. And I think we should start spending some resources to figure out how we can make the physician workplace more user-friendly. How can we make it a happier place to be? What can we do to institute regulations, guidelines, software, and bureaucracy to try it out on the workforce for a while to make sure that they're satisfied and that it's not making their lives more miserable?